Welcome to Lesson 1, where we will focus on eating disorders. And the verse guiding this lesson is from the Song of Solomon, chapter 4, verse 7. You are altogether beautiful, my love. There is no flaw in you. Sadly, individuals suffering from an eating disorder often don't see the beauty that is within them and that they are, in fact, a child of God made in God's image. And so this is crucial, and spiritual focus is needed along with the physical and emotional treatment of the individual. The DSM-5 combined sections of feeding and eating disorders of childhood along with their previous section on eating disorders into one section, now labeled feeding and eating disorders. Previously, there were several disorders that were classified in the section disorders usually first diagnosed in infancy, early childhood, or adolescence. That section has now been eliminated, and those disorders are listed here. And those include pica, rumination disorder, avoidant restrictive food intake disorder, as well as anorexia nervosa, bulimia nervosa, and the newest addition to the eating disorder family, that of binge eating disorder. There are also 2 additional disorders for those that do not meet full criteria, and that includes unspecified eating disorder or other specified feeding or eating disorders. Feeding and eating problems in early childhood can cause significant problems, such as failure to thrive. And failure to thrive can occur from both physical as well as social causes. Some children you will see have selective eating or extreme fattiness, or they're extremely picky. Some children have restrictive eating, where the child has a very small appetite and will only eat a very small number of foods and in very small amounts. Some children can have a functional dysphagia or a fear of choking or vomiting, and so certain texture foods will be avoided. There can be food refusal as well, and that can be a refusal to eat for other reasons other than wanting to be thin or feeling as if they are overweight. So with young children especially, you can see some food avoidance as a component of an emotional disorder or a mood disturbance, and as well can cause significant weight loss. Now, you will often see children on psychostimulants that may have difficulty with gaining weight or suffering from weight loss, and that is a problem that requires significant monitoring, which we will discuss. As well, we do have children who may have weight gain that's associated with antipsychotic medications, and they may have an increased appetite. And of course, anorexia and bulimia nervosa can both occur in childhood as well as adolescence. Now, there are a number of similarities as well as differences between anorexia nervosa and bulimia nervosa. Of course, they're both eating disorders and have a pattern of abnormal eating. Both of them also have a fear of gaining weight. And both of them also have the experience of a body shape distortion, where they perceive their appearance as different than it actually is. Now, the differences between anorexia nervosa and bulimia include that anorexia involves restricting food intake and weight loss that is less than expected for that age or developmental stage. And with bulimia nervosa, you see recurrent episodes of binge eating that are often associated with a sense of a loss of control and compensatory behaviors in order to prevent weight gain after binging, such as vomiting, purging, and there are some behavioral types of purging as well, such as excessive exercise or the use of laxatives. And the weight of an individual with bulimia is usually average or above average, where with anorexia nervosa, you have persistent behaviors to avoid weight gain, such as dieting, exercising, and restricting. And usually the appearance will be underweight, significantly underweight. And you may see some types of purging with anorexia nervosa as well, but you will not see the binge pattern. The epidemiology of anorexia nervosa is pretty high in Western cultures. Actually, life history of anorexia is estimated to be 1% in 20-year-old women. And it's considered to be the most common cause of weight loss in adolescent girls and reason for an inpatient admission. The average age of onset is between 15 and 19, and they certainly have an increased risk for psychiatric as well as medical comorbidities. There is a 90% prevalence with females, although you will see, obviously, then the remaining 10% impacting males. And the epidemiology does vary according to different cultures as well, and is often seen as more prevalent in Eastern versus some of the, in Western rather, versus the Eastern cultures. Some cultures do not have a significant prevalence of eating disorders at all. In the US, we do have a higher incidence than some other countries. And so the difference with bulimia and binge eating disorder surrounds the purging. So both bulimia nervosa and binge eating disorder involve the eating of larger quantities of food, and as well may both have severe angst rumination about it afterwards. But with binge eating disorder, we don't have the compensatory techniques of purging, so we don't see the vomiting or the laxative use or the over exercising. And of course, eating disorders are more common in our society because of the media glorification of the thin appearance. And as well, the readiness and availability of high calorie snack foods. And less of a structure today in set meal times in our society. It is estimated that at least 12% of adolescent girls have some form of either bulimia nervosa or binge eating disorder. Homosexual males are thought to be more vulnerable than heterosexual males, and there is increasing prevalence of the experience, especially of binge eating disorder in men. And the risk factors, of course, do include nature and nurture. So we have some complex genetic factors going on, And there have been identified as increased frequency with mono and dizygotic twins. And there is a possible increase of the experience of anorexia with autism. Individuals with anorexia often come from a family with high perfectionistic and obsessive traits. There will frequently be a comorbid disorder of obsessive compulsive disorder is not uncommon. Bulimia or binging often will demonstrate a family with a history of obesity, depression, and substance misuse. Eating disorders are also commonly comorbid with borderline personality disorders. And again, the diagnostic criteria for anorexia nervosa include restrictive eating that leads to deliberate weight loss or failure to grow and increase weight and height as expected according to age and gender. And there also needs to be a fear of weight gain or persistent failure to maintain a normal, healthy weight, and disturbance of body image, which translates to any type of distress or perception that their body is too fat. To provide the diagnosis of anorexia, you need to have a loss of 15% of the minimal normal weight, a BMI less than 17.5. Of course, there are some exceptions, and children and adolescents, you're going to watch for them to fall off trends in growth charts. So that would be one way to identify anorexia nervosa in um, younger children and adolescents. And typically you'll see amenorrhea with females and low testosterone levels for males that can lead to atrophied genitalia. And the SCOP is a brief screening tool that you can use to identify a potential for an eating disorder. And the mnemonic stands for these 5 questions. Do you make yourself sick because you feel uncomfortably full? Do you worry that you have lost control over how much you eat? Have you recently lost more than 1 stone or 6 kilograms in weight in over a 3-month period? Do you believe yourself to be fat when others say that you are thin? And the 5th question you don't see on the slide is, would you say that food dominates your life? And here in this slide, we see a picture of a child falling off of the growth chart. So here we see them actually moving in the wrong direction. And so this would be a warning sign that psychiatric evaluation to identify any potential eating disorders would be warranted. And so the criteria for binge eating disorder, which is the newest disorder in the DSM-5, is the experience of recurrent, regular binge eating that occurs weekly for at least 3 months. So it has to be a regular experience and occurring for at least 3 months. And binge eating consists of eating a larger amount of food than most people would eat in a 2-hour period. As well, the individual has a sense of a lack of control over their eating during that time. And as we said previously, with a binge eating disorder, you do not have any purging, vomiting, fasting, or compulsive exercise. Body image concern is not necessarily a requirement. But what is a requirement is that the individual experiences marked distress following a binge eating episode. As well, they need to have at least 3 of these other symptoms: eating more rapidly than normal, eating until uncomfortably full, or large amounts when not hungry, eating alone due to embarrassment, and feeling disgusted, depressed, or guilty afterwards. And the criteria for bulimia nervosa include the binge symptoms we just reviewed, as well as purge symptoms, which can include self-induced vomiting, misuse of laxatives, diuretics, or other medications, fasting, and excessive exercise. Both of these symptoms have to be occurring weekly for a period of 3 months. There are several screening tools, such as the bulimic inventory test or the bulimic investigatory test, as well as the EATS. And we'll go over some of these in more detail. So, other specified feeding or eating disorders can include things such as atypical anorexia nervosa or a subthreshold bulimia nervosa, a binge eating disorder of low frequency or limited duration, a purging disorder, or night eating syndrome. As well, unspecified feeding or eating disorders can include any eating disorder that does not meet full criteria. And an avoidant restrictive food intake disorder is another type of disorder that is commonly seen in individuals with autism spectrum disorder. And take a look at some of these rating scales: the Eating Disorders Examination, the Eating Disorders Inventory, the Children's Eating Aptitudes Test, or the Morgan Russell Average Outcome Scale. Some eating disorder screening tools are more in depth, and whenever you have a positive screen for one of the brief inventories or the brief screening tools, a more detailed inventory is needed. The BITE, the bulimia investigatory test, involves 33 items. So it's important to elicit the full symptoms to include. Again, a positive screen to the SCOFF is certainly indicative of a possible eating disorder, but a more detailed inventory is needed to assign a diagnosis. So more detailed assessment. In addition to rating scales, assessment also needs to include a physical exam as well as a full psychiatric evaluation. It's important to assign individuals, children, adolescents in this area, assignments such as completing a food diary, 24-hour recall, but sometimes a more extensive food diary can be helpful. And family can help with completing the food diaries as well. Growth charts are essential, as identified earlier. And family history and involvement is important, and it can be very helpful to observe a family at meal times and observe some of the family dynamics that are occurring. Some that may be inadvertently reinforcing some of these behaviors. Of course, diagnostics that you need to include would be monitoring height and weight, and some routine blood tests such as glucose, thyroid, electrolytes, liver function tests, pregnancy, a CBC, and cholesterol. Unexpected, you will see actually an elevated cholesterol, hypercholesteremia with anorexia. You also want to assess an EKG as well as bone density. Some common comorbidities for eating disorders include depression, anxiety or obsessive compulsive disorder, autism spectrum disorder, emerging borderline personality disorder, because often we will not diagnose a personality disorder in a child or young adolescent, substance misuse, the diabetes, cystic fibrosis, GI conditions, obesity, and chronic fatigue syndrome can be some of the medical comorbidities. Anorexia nervosa is one of the most lethal psychiatric conditions. 40% achieve full recovery. Now, sadly, that means that 60% do not. There is a small percentage that does have a severe as well as enduring course. The average time to recovery is 6 to 7 years. And so this is a disorder that really is persisting. And bulimia, however, can remit spontaneously in young adolescents, and 50% achieve remission at 5 years. Untreated symptoms are likely to persist with significant impact. And so treatment is really necessary, but unfortunately, bulimia nervosa is often a secret and an undiagnosed disorder. Management of anorexia nervosa is very challenging. And of course, we are um, looking at the physical needs as well as the emotional needs as well as the spiritual needs. When you have a precipitous weight loss of more than 1 kilogram a week, or if you have purging, substance use, or weakness going on, these are medical emergencies. There are some programs where inpatient admission is needed for treatment of eating disorders that could include refeeding. And this is important because the consequences of starvation on the developing brain are significant. And so family and caregiver education is important. Also, a dietitian is usually an important member of this interdisciplinary treatment team. Family-based therapy is most effective, as well as individual therapy for the likely comorbid psychiatric disorders such as depression. As demonstrated earlier, eating disorders can run in families. So again, we have the nature and the nurture component going on. And so there are some models of family therapy that are helpful. Here's one example of the Maudsley model of family therapy, where the family is encouraged to take the illness very seriously. And anorexia is externalized and talked about as a life-threatening illness, because it is. So we want to induce this sense of crisis so that everyone is really getting out of that denial and really focusing on intervention. And the therapy, though, is not focused on causes for the anorexia and is to avoid at all costs blaming the family. Rather, recovery is promoted by placing the responsibility for recovery with the family as well as the professional team. And the family is assumed to know best how to feed their child. They may need some support from the medical staff, but we know that the family is an expert in caring for their children. And so With the Maudsley model of family therapy, the adults need to retake control until the child can feed themselves. And so, appropriate autonomy for their age level is encouraged only when the child is adequately nourished. It's really important to work with families with children and adolescents with eating disorders. And oftentimes you will note that they come with significant guilt, feelings of guilt. And so it's important to help them in dealing with this. And I like to tell families that they are not the cause of their child's eating disorder, but they are the key to their recovery. So we really need to engage them in the therapeutic process in this manner. So we need to help children to see the links between their anorexia and other symptoms that they dislike, such as weariness, agitation, obsessional thinking patterns, a preoccupation with food, or with anorexia, a preoccupation with food avoidance, sleeping problems, feeling cold because they will have cold intolerance due to a lack of body fat, as well. Um, the motivational approach will focus on um, things that they don't like about the anorexia, such as their lost friendships and their inability to join in socially with their peers. Oftentimes, they'll have some failure going on in school or in their sports. And of course, the negative attention and fussing that's going on by the parents. So, helping children see the link between their anorexia and things they don't like is a helpful approach. Again, just remember your motivational interviewing skills. Now, as well as helping children see the things that they don't like about their anorexia, we want to use the same motivational approach to help the children see the benefits of weight gain, such as they'll have more energy, they'll have a clear head, they will be resistant to cold, they'll be growing in height, and they will have the capacity to have fun with their friends and be well enough to join in games. And so the psychodynamic case conceptualization involves several concepts. One being their feeling of having power or control over different things. So one of them is the power to cause people to care about them and their ability to then have control and placate them through their eating. And as well, they often feel some relief from sexual or social demands with the eating disorder. And they have that sense of control over their body. And young patients need to learn new coping techniques so that they can cope with these aspects of life in different ways rather than starving themselves. And now for the management of eating disorders. Food is medicine. We know this. We know that nutrition is so important, but even more so here. Food must be taken in amounts prescribed at the times prescribed. And the choice for the child is how they take the medicine: orally as food, orally as a supplemental drink, or a nasogastric tube. Again, sometimes refeeding interventions in the inpatient setting are needed. And there is little evidence for psychoactive medications, and it's very important to avoid medications that have the QT prolongation because, again, of the risk for EKG changes with their electrolyte imbalances. Now, there's some evidence for olanzapine or other antipsychotics to help with rumination and to aid weight gain in anorexia. But again, being careful to monitor cardiac status for sure. Now, when considering inpatient versus outpatient, of course, safety is the key. We always want to provide care in the least restrictive setting. Outcomes are better in outpatient clinics that have eating disorder specialists. So, you really do want to seek treatment through a specialty care center, such as the Renfrew Center. Even general outpatient child and adolescent psychiatrists can have better outcomes than some inpatient hospitalizations. So, psychiatric care is very important. There are guidelines now that recommend outpatient care if the patient with anorexia is medically stable. When there is no outpatient clinic available, then certainly considering the use of telemedicine, which we're all very good with these days. Now, refeeding with anorexia must be done very carefully because it can cause a potentially fatal shift in electrolytes and fluids if it is done too fast, if it is improperly balanced, and problems such as hypophosphatemia, hypomagnesemia, hypokalemia, gastric dilation, congestive cardiac failure, severe edema, confusion, and coma or even death can occur. So there's some criticism about guidelines for refeeding, and as always, adequate monitoring is necessary whenever this approach is used. Now, for the treatment of bulimia and binge eating disorder, we do have an FDA approved medication, and that is fluoxetine. And the dose may need to be titrated up to 60 milligrams. Cognitive behavioral therapy that targets bulimic symptoms is also considered the gold standard for treatment. There are a number of self help books, CDs, as well as online, internet, and social media based programs when access to a trained therapist is not available. The interpersonal therapy model for bulimia can be very helpful. And another treatment approach is Fairbairn's CBTE, or cognitive behavioral therapy for eating disorders, for patients that are 15 or older with a BMI of at least 15. A coordinated response is key. Initially, monitoring after meals to prevent purging can be helpful with bulimia nervosa. This time, though, with the one-to-one monitoring should be a therapeutic opportunity rather than we don't want the child or adolescent to feel like they're being monitored or policed, but rather use it as a support. Um, and hopefully they're, assisting them in achieving their own goal of keeping the food in their system and nourishing their body. When they return to school, of course, there is less supervision, and competitive academics and sports in the environment can be a trigger. Group therapy is helpful for ongoing support and can be successful for bulimia and binge eating disorders. There's growing evidence for multifamily groups, and certainly we have a program here in West Palm Beach. Via NUR is an excellent eating disorder treatment program, and they use multifamily groups and have family day where all the families come together and the therapist will meet with all of them. Of course, you could feel like, well, that's a HIPAA violation, but as long as they sign their consent and they're okay with joining in the multifamily group therapy, it can be quite helpful. Again, anorexia does have a very significant prognosis, where some older studies showed 20% mortality rates. They're a little bit better now. And the average time to recovery, again, is 6 to 7 years. So this is something that takes time. And the younger the individual is with the more intensive treatment tends to show better outcomes. There are some effects with anorexia on later fertility. And again, high death rates can be related to ambivalent overdoses or the comorbid existence of a substance use disorder. As with other mental disorders, prevention is key. Prevention, early identification, and intervention is so important. Prevention is usually best in groups at schools, at community centers, or athletic clubs. And targeted programs can be effective for individuals at higher risk. We have certain groups such as dancers, models, some athletes such as gymnasts who are at a higher risk. For these individuals participating in these types of sports and activities, having a minimum BMI for um, for participating would be helpful. Anti-obesity campaigns are certainly important, but their emphasis must be on healthy nutrition and exercise rather than weight reduction or focus on appearance, images, or weight loss.